Our next our next topics are shock, ivio, access, TXA administration, and fluid resuscitation. Here we will talk about hemorrhagic shock. We'll identify the signs and symptoms of hemorrhagic shock in TFC. Identify the importance of level of consciousness and radial pulse as indicators of shock in tactical foot care. So, intravenous or intraosseous access is indicated if the casualty is in hemorrhagic shock or at significant risk of shock, or if the casualty needs medications but cannot take them by mouth. If vascular access is needed but not quickly obtainable via the IV route, use the IO route.
Shock is inadequate blood flow to the body tissues. Shock can have many causes, but on the battlefield, it is typically caused by severe blood loss. Hemorrhagic shock is a leading cause of preventable death on the battlefield. The normal adult blood volume is 5 liters. 500 milliliters of blood loss is when you donate a unit of blood at the blood bank. Physiology is normal, and there's no danger from this level of blood loss. After 1,000 milliliters of blood loss, the only sign may be a slightly elevated heart rate. After 1,500 milliliters of blood loss, symptoms may include anxiety, weak pulse, elevated heart rate, low blood pressure, and increased respirations, but still, the casualty is not likely to die from this. 2 liters of blood loss likely represents ongoing, uncontrolled hemorrhage. The casualty may be lethargic with a weak pulse, elevated heart rate, low blood pressure, and rapid respirations. At this point, it is quite possible they may die from blood loss. This is hemorrhagic or hypovolemic shock. With continued blood loss, the casualty has now lost 2,500 milliliters, or half of the blood in his or her body. This level of hemorrhage is likely to be fatal. Your job is to not let them lose this much blood. Remember, the most reliable signs of shock on the battlefield are a decreased level of consciousness without TBI and/or a weak or absent radial pulse. If signs of shock are present, control the bleeding first. Hemorrhage control takes precedence over infusion of fluids. Not all casualties need IVs. Do not start IVs on casualties who are unlikely to need fluid resuscitation or IV medications. Do not use for minor injuries as it wastes supplies, takes too much time, and can distract from other more important care or tactical concerns. The indications for IV access are fluid resuscitation for hemorrhagic shock or significant risk of shock, such as GSW to the torso. The need to give medications, but the casualty is unable to swallow, is vomiting, or has a decreased level of consciousness. A single 18-gauge catheter is recommended for access. Don't insert an IV distal to a significant wound. A saline lock is recommended instead of an IV line, unless fluids are needed immediately. Flush saline lock with 5 cc's normal saline immediately, and then every 1 to 2 hours to keep it open. If unable to start an IV and fluids or meds are needed urgently, insert an interosseous line. Tranexamic acid, or TXA, helps to reduce blood loss from internal hemorrhage sites that can't be addressed by tourniquets and hemostatic dressings. Tourniquets and combat gauze do not work for internal bleeding. TXA does. TXA is indicated if a casualty is anticipated to need significant blood transfusion. For example, hemorrhagic shock, one or more major amputations, penetrating torso trauma, or evidence of severe bleeding. Administer 1 gram of TXA as soon as possible, but not later than 3 hours after injury. When given, the TXA should be administered over 10 minutes by IV infusion. TXA should not be given with Hextend or through an IV line with Hextend in it. If there is a new onset drop in BP during the infusion, slow down the TXA infusion. Survival benefit of TXA is greatest when given within 1 hour of injury. Give it as soon after wounding as possible, but do not give TXA if more than 3 hours have passed. Survival is decreased if TXA is given after 3 hours. Possible side effects of TXA include nausea, vomiting, diarrhea, visual disturbances, and hypotension if given as a bolus. Do not be deterred by possible side effects. The important thing is to stop the bleeding and save the casualty's life. The resuscitation fluids of choice for casualties in hemorrhagic shock are shown here, in order from most to least preferred. Whole blood is the most desirable, and crystalloids are the least desirable. Currently, neither whole blood nor apheresis platelets collected in theater are FDA compliant because of the way they are collected. Consequently, whole blood and 1:1:1 resuscitation using apheresis platelets should be used only if all of the FDA compliant blood products needed to support 1:1:1 resuscitation are not available, or if 1:1:1 resuscitation is not producing the desired clinical effect. The first step in fluid resuscitation is to assess for shock. If not in shock, no IV fluids are necessary, but fluids by mouth are permissible. If in shock and blood products are available, transfuse with the best available products. If blood products are not available, transfuse with Hextend or crystalloid. Hextend is preferred over crystalloid because the volume needed is less and it lasts longer. Do not pause between units of resuscitation fluids. Reassess after each unit of blood product or 500 cc's of Hextend or crystalloid. Continue until a palpable radial pulse, improved mental status, or SBP of 80 to 90 is achieved. Shock increases mortality in casualties with head injuries, so you have to be more aggressive with your fluid resuscitation. Resuscitate until there is a normal, not just palpable, radial pulse or a systolic BP of at least 90. If shock recurs, recheck all external hemorrhage control measures to ensure they are still effective and repeat the fluid resuscitation. The goal of fluid resuscitation is not to restore a normal blood pressure. The goal of fluid resuscitation is an improved state of consciousness or palpable radial pulse, corresponding to a systolic blood pressure of 80 to 90 millimeters mercury. If the blood pressure goes up too much, this may interfere with the body's attempt to clot or disrupt a clot that is formed, essentially popping the clot. Also, remember to initiate hypothermia prevention measures while fluid resuscitation is being accomplished. Hypotensive resuscitation saves lives in non-compressible hemorrhage. Do not start your fluid resuscitation by giving 2 liters of LR or NS wide open before reassessing your casualty. Remember, if the casualty is not in shock, don't use your IV fluids. Save IV fluids for casualties who really need them. The next person to get shot may die if he or she doesn't get fluids. In summary, assess for shock and establish IV or IO access after external hemorrhage is controlled. If indicated, give TXA as soon as possible and before 3 hours. Use the best available resuscitation fluid, but do not over-resuscitate.
So, not every casualty needs an IV. Don't insert an IV distal to a significant wound. A saline lock is recommended instead of an IV saline unless fluids are needed immediately. It's much easier to move a casualty without an IV line and bag attached. There is less chance of traumatic disinsertion, provides rapid subsequent access if needed, and conserves IV fluids. Don't hand fluids unless the casualty really needs them. Here is an excellent way to ruggedize an IV that was developed by the Army Rangers. Don't forget to flush the saline lock. If it will clot off if you don't. It must be flushed immediately and then flushed every 2 hours if IV fluid is not running. The second catheter for the IV line is inserted right through the tegaderm. The Velcro strap helps prevent traumatic disinsertion of IV line. Even if the IV line is pulled out, the saline lock will remain in place. This ruggedized IV technique has worked very well on the battlefield. Let's watch.
Site selection, the IV site has already been cleansed. Constricting band is in place. The tegaderm is resting to cover the IV site in its entirety. Sharp. IV plug is put on. The site is covered up 100% with a tegaderm dressing. Cut. The saline lock is flushed with 5 cc's of normal saline. You penetrate through the tegaderm and through the IV plug. At this time, the determination has been made that the individual has controlled hemorrhage and is in need of fluid. Notice that the 18 gauge, all of the devices that have these types of peelbacks are primed, so easy access. At this time, what we do is we introduce the 18 gauge 1 1/4 through the saline lock and rest it at the hub. We then retract, discard the needle into a sharp shuttle, and apply fluids through that port. Why don't you shift over here and show the delivery of fluids, please? Okay. This is a linebacker IV tubing or saline lock securing device. What we do at this point, never losing control of the tubing, we place this inside, put the tubing across it, lock it on itself, and wrap this around the arm. This secures the IV tubing while not impeding the flow of IV fluids. At this time, the determination during these fluid challenges, the determination has been made that the individual must be moved immediately. At that time, just take this off, pull the IV out, and disembark. The line or the saline lock site is still patent.
Welcome, my name is Stefano, and today we're going to be discussing proper placement and insertion of an intraosseous device. This procedure is indicated when you cannot obtain peripheral vascular access and the patient requires life-saving medication or fluid. First step is you're going to prep your equipment. Be sure to bleed the tubing so you do not introduce air into the sternum. Next, we are going to cleanse our site. After cleansing the site, we can locate our site by palpating the sternal notch midline on the manubrium. With non-dominant index finger, we are going to palpate sternal notch and place our target patch midline on the manubrium. After securing your sternal IO device, positioning ourselves at the head of the casualty, secure the IO device in both hands, aim it over the target zone, and be sure to introduce with equal pressure. We are now going to flush the IO tubing. Secure your tubing and attach it to the IO catheter. Be sure to aspirate and visualize for return of marrow or blood. Then flush your IO tubing. After flushing the IO tubing, we are going to secure the line. After securing the IO tubing, you can now administer fluids or medications in the IO device. Be sure to reassess your intervention, check your casualty's vitals, and annotate all patient care on a DD Form 1380.
First one, not recommended if patient is of small stature, weight of less than 50 kilograms and less than 20 years old. Also, first not recommended if your casualty have fractured manubrium, sternum, flail, chest, or significant tissue damage at site, trauma, infection. Also, if casualty have several osteoporosis and private sternotomy or and scar. The ivio device made for long bone insertion for bones like humerus and tibia. It has a balloon hub and its needle is 25 millimeters long. There are also pediatric and large patient devices. The packaging for these devices is markedly different. The long bone device package is marked not for sternal use. Intraosseous needles designed for long bone insertion have the potential to perforate the sternum, a thinner and less dense bone. In this situation, IV fluids may be introduced into the mediastinum. And of course, make sure you use the correct device for the site chosen.
Welcome, my name is Stefano, and today we're going to be discussing proper placement and insertion of an intraosseous device. This procedure is indicated when you cannot obtain peripheral vascular access and the patient requires life-saving medication or fluid. First step is we are going to prep our equipment. We are going to prime our IO tubing so we do not introduce air into the bone cavity. Our tubing is primed. We are now going to select the appropriate placement site and cleanse our area. For proximal humerus, we are going to place our manual needle set directly into the greater tubercle on the upper aspect and just lateral on the humerus. We are going to palpate the appropriate placement site. We're going to secure our manual needle set and at 90 degrees into the greater tubercle, keeping our wrist in a neutral position, we're going to begin to insert the manual needle set. Being sure to not flex or extend the wrist, we are going to gently rock back and forth until we feel the bone give way. We're going to remove the stylet and attach our IO tubing. Next, we are going to flush our IO tubing. I have good stability at the site, indicating proper placement. Prior to flushing our IO tubing, we're going to aspirate to visualize return of marrow or blood. We can then flush our IO tubing. With stability at the site and ease of flush, we have confirmed placement. We are now going to place a protective bulky dressing over the IO site. Taking 2 pieces of gauze, we are going to pad each side of the IO site. After securing the bulky dressing for our intraosseous device, it is now ready to receive medication or fluid for our casualty. Remember to continually reassess your intervention, assess the casualty's vitals, and document all patient care on DD Form 1380.
Of course, don't practice on one other. In the past, a number of student volunteers have been taken to surgery to have IO needles removed. There is a risk of osteomyelitis, and of course, you need to train on in intraosseous simulators, not classmates. Next step is tranexamic acid. If a casualty will likely need a blood transfusion, for example, presents with hemorrhagic shock or one or more major amputations, penetrating torsal trauma, or evidence of several bleeding. Or if the casualty has signs or symptoms of significant TBI or has altered mental status associated with blast injury or blunt trauma. Administer 2 grams of tranexamic acid via slow IV or IO push as soon as possible, but not later than 3 hours after injury. TXA helps with hemorrhage control. Tourniquets and hemostatic dressings help by stopping hemorrhage from external sites. TXA helps to reduce blood loss from internal hemorrhage sites that can't be addressed by tourniquets and hemostatic dressings. TXA doesn't promote new clot formation. It prevents forming clots from being broken down by the body. It helps stop internal bleeding. It helps prevent death from hemorrhage. 2 major studies have shown a survival benefit from TXA, especially in casualties that require a massive transfusion of blood products. Survival benefits is greatest when TXA is given within 1 hour of injury. The greatest decrease in blood loss is seen when TXA is started as SAP. Give it soon after wounding as possible. Survival benefit is still present when given within 3 hours of injury. It is just common sense if you are trying to stop bleeding to do that as soon as possible. Bleeding should be stopped to give TXA without delay. Recommended temperature range of storage 59 86 degrees Fahrenheit. You must protect this drug from environmental extremes. Store and transport TXA in air-conditioned spaces. On missions, carry it in a small insulated container. In very cold temperatures, carry it next to your body. Return to room temperature storage after each mission. Fluid resuscitation. Assess of hemorrhagic shock. Assess of hemorrhagic shock. The resuscitation fluids of choice for casualties in hemorrhagic shock are listed from most to least preferred are cold stored low titer, whole blood, prescreened low titer, zero fresh whole blood. What here you can see plasma, red blood cells, and platelets in a 1:1:1 ratio. Plasma and RBCs in a 1:1 ratio. Plasma or RBCs alone. Hypothermia prevention measures should be initiated while fluid resuscitation is being accomplished. If your casualty is not in shock, of course, no IV fluids are immediately necessary. Fluids by mouth are permissible if the casualty is conscious and can swallow. If your casualty in shock and blood products are available under an approved common or theater blood product administration protocol, resuscitate with whole blood, or if not available, plasma, RBCs, and platelets in a 1:1 ratio, or if not available, plasma and RBCs in a ratio 1:1, or if not available, reconstitute dried plasma, liquid plasma, or thawed plasma alone, or RBCs alone. Reassess the casualty after each unit. Continue resuscitation until a palpable radial pulse. Improved mental status or systolic blood pressure of 80 to 90 is present. If a casualty in shock and blood products are not available under an approved command or theater blood products administration protocol due to tactical or logistical constraints, resuscitate with extant or, if not available, lactated ringers or plasmolite A. Reassess the casualty after each 500 milliliters IV bolus. Continue resuscitation until a palpable radial pulse, improved mental status, or systolic blood pressure of 80-90 millimeters is present. Discontinue fluid administration when one or more of the above endpoints has been achieved. If a casualty with an altered mental status due to suspected TBI has a weak or absent radial pulse, resuscitate as necessary to restore and maintain a normal radial pulse. If blood pressure monitoring is available, maintain a target systolic blood pressure of at least 90 millimeters. Reassess the casualty frequently to check for recurrence of shock. If shock recurs, recheck all external hemorrhage control measures to ensure that they are still effective, and repeat the fluid resuscitation as outlined above. Currently, neither whole blood nor apheresis platelets collected in theater are FDA complaint because of the way they are collected. Consequently, whole blood and 1:1:1 resuscitation using apheresis platelets should be used only if all of the FDA complaint blood products need to support 1:1:1 resuscitation are not available, or if 1:1:1 resuscitation is not producing the desired clinical effect. Don't use your IV fluids unless the casualty really needs them. The next person to get shot may die if he or she doesn't get fluids. Conserve precious medical supplies on the battlefield. When resuscitating a casualty in hemorrhagic shock, whole blood is best, followed by blood products, extant, and then colloids. Why not use these fluids? Albumin is a colloid derived from human plasma that has been used to resuscitate individuals in hemorrhagic and other types of shock. But patients resuscitated with albumin have a higher mortality rate than those resuscitated with saline. Volumen is a synthetic colloid. don't try to restore normal blood pressure. As you infuse fluids, the blood pressure goes up. If it goes up too much, this may interfere with your body's attempt to clot off an internal bleeding site, both by diluting clotting factors and by increasing the pressure to the point where the clot is disrupted by the hydrostatic force extent by the IV fluid. How much fluid should you give? Reassess the casualty after each unit of blood product or 500 milliliters of fluid. Continue resuscitation until a palpable radial pulse, improved mental status, or systolic blood pressure of 80-90 is present. Don't over-resuscitate. Too much fluid or blood may raise blood pressure higher than needed and increase any ongoing non-compressible hemorrhage. If a casualty in shock is not responding to fluid resuscitation, consider untreated tension pneumothorax as a possible cause of refractory shock. Thoracic trauma, persistent respiratory distress, absent breath sounds, and hemoglobin oxygen saturation less than 90% support this diagnosis. Treat as indicated with repeated needle decompression or finger thoracotomy, chest tube insertion at the fifth intercostal space in the AL, according to the skills, experience, and authorizations of the treating medical provider. Note that if finger thoracotomy is used, it may not remain patient and finger decompression through the insertion may have to be repeated. Consider decompressing the opposite side of the chest if indicated based on the mechanism of injury and physical findings.